Okay, so let's move on with the case. So the patient did, as we mentioned, got sipuleucel-T, was being followed by the urologist, getting scans actually every 6 months. So a year later, patient still asymptomatic, minimally symptomatic, maybe taking some nonsteroidals, but not routine use of opiates, and his PSA has gone to 10 nanograms per ml. Gets a repeat staging at that point and shows really the lymph node at that point really is unchanged, but he does have progression on technetium-based bone scanning with 2 new rib lesions. So again, a little bit of progression, PSA is going up, minimally symptomatic, taking nonsteroidals to control his pain.
So what's the first thing? We've got all these new agents. We've got Xtandi and we've got potentially using Taxotere. We'll have, I guess we're going to talk about alpha-rad in a little while. This is, for payment issues, it seems like Zytiga has a little strength over the options, just because they have the 302 trial showing efficacy in this space. And I think there's just been some momentum because it's been on the market longer. We're a little more familiar with the Zytiga. So we'll typically start with Zytiga and prednisone in this setting if there has been no recent Provenge, and see excellent results with that in this setting.
So Evan, talk to us a little bit, because I know there's this area of controversy with the 302 back, and which, again, Zytiga got approved in the pre-chemotherapeutic space for CRPCM1 disease. It was an interesting study because it had 2 co-primary endpoints, one of radiographic progression-free survival, which was statistically significant, and overall survival, which did not meet the predetermined boundary, but yet was a trend towards overall survival. Can you comment a little bit about that?
Well, I think that it's pretty clear for anyone that uses Zytiga that there's a very clear benefit. The progression-free survival benefit was rather dramatic. The overall survival p-value, I believe, was 0.01, and that didn't cross the boundary, as you mentioned. However, there are contributing factors as to why it might not have. For instance, after progression, patients were blinded, and after progression, Zytiga was already FDA approved after chemotherapy. So there were plenty of patients that on the control arm, the placebo arm, did receive Zytiga. They also eventually did allow crossover after the data was unblinded and it was a positive study for progression-free survival. So many of the patients on the control arm did receive Zytiga. So it makes it harder to show a difference when they actually receive the drug. So that being said and done, I think that overall survival becomes less important, and I think the FDA recognizes that, and again, it's a dynamic process. The field is coming around to figuring out that we need to move forward with newer endpoints, and I think radiographic progression-free survival is fine, especially in this setting when the drug clearly shows an overall survival benefit already in 1 large randomized controlled trial. I really think it's no debate. This is just a good drug.
If I can make one comment. We talked about this boundary with the overall survival. The way the trial had to be designed was you just didn't have to show a clinically significant, but the extent of that was a p-value that was really down around 0.008 or something like that, this O'Brien boundary. So because this drug was being approved in an earlier state, that was a much higher bar to pass. So you look at the curves, the survival is there. When you look at the fine print, it's not clinically significant. But again, that clinical significance that they had to show for the abiraterone was extraordinarily high. And I am not aware, and again, maybe Evan and Mark know about this, of any other study that had to show such a high degree of statistical significance and overall survival to get approval. And maybe they might know about it, but I've never seen anything that had to reach such a high bar for survival.
Yeah, it's because of the preset interim analyses that were done at early intervals. I think the other point to bring up here is the fact that patients are living longer, and after progression on Cougar 302, I think the median period of time patients lived was still another 18 months, and that's after progression, and the patient's progression-free survival was long on the study. So think about all the other treatments that they got afterwards that affected things. So you can't always ask for the overall survival bar when a patient's going to live for a very, very long time and receive a lot of other treatments, it's not a fair criteria to use.
Lenny, your point's well taken. There is a difference between statistics and clinical, and I think most of us, said, yeah, that is clinically, that is a huge difference. So, okay, so Mark, you had mentioned a little bit about Xtandi. Larry, you do a lot of clinical trials over at Tuck. What's been your experience with Xtandi? Tell us a little bit about where it's approved by the feds. It obviously got compendium listing in December of 2012. About the same period of time when Zytiga got their pre-chemotherapeutic approval.
All right. Well, Xtandi or enzalutamide, it is approved right now in the post-chemo metastatic prostate cancer, castration-resistant prostate cancer part of the continuum. And I have found it to be pretty effective both in my clinical trials and patients that I have on it. I think that you see a pretty dramatic decline in PSA. Just looking at the clinical trials, there has been some progression responses and PSA responses that have been, I think, are very good. And they've been very dramatic. So, and I think that the drug does not have a lot of downside. It's very simple to administer. You don't have to give it with prednisone. And it's a once-a-day drug, 160 milligrams a day. And so I found it to be effective. And I'd like to see it, and that was in the AFFIRM trial, is the study they used to get the approval in the post-chemo space. And now the results of the PREVAIL trial, I think, are going to become available. And I think they're going to try to get approval in the pre-chemo space pretty soon here.
I thought the great thing about that AFFIRM trial is that, about 85% of those people had already experienced at some point in their therapy bicalutamide. I mean, so they had already been bicalutamide. I think in the urology world, there is sort of this oversimplification that this is just a super androgen receptor blocker, and it clearly, as you had mentioned, it is a pure androgen receptor blocker. We don't see that agonist effect. We don't see the upregulation of the receptor. And as you pointed out, Larry, what makes it attractive to a lot of the urology field is that there are no steroid requirements based upon the mechanism of action, although I believe about a third of the patients at the time of randomization actually were on steroids primarily because they had already received docetaxel and couldn't necessarily be weaned off their steroids, is my understanding.